So with that, I'm going to turn it over to the next speaker, who is actually Dr. Haritas, who's going to be speaking, and thank you very much.
Thanks, Tracy. Hi, everyone. So I feel that typically towards the end of a conference, you received a lot of great information, and it's a sign when your brain is like processing all the information you have received. So what I'm going to do over the next couple of minutes is just give you a couple of high yield points over 15 minutes or less. So that way you can have a few really important points to keep in mind on managing seizures, clusters, and status epilepticus. I'm available and I'll be around if you have any questions that you want to chat about offline. So the learning objectives today are going to be to understand the nuances of managing seizures, especially as it pertains to your loved ones, define what status epilepticus actually is, identify rescue regimens that are utilized as an outpatient, and understand when to pursue outpatient versus ER or inpatient management. And at the end, we're going to have you name one seizure safety practice you would like to adopt. Hopefully this time around the Mentimeter will work, but we'll power through this together. Okay, so let's talk about managing seizures. By a show of hands, can I see how many of you feel that when you're trying to decide what's the next medication option, do you tend to feel as if we're just throwing darts at a dartboard? By a show of hands, can I see? I see a lot of hands. Okay, all right. I see many hands. I'm not sure if some of the providers might have thrown their hands up. I don't think so, but let me tell you guys, I wanted to walk you guys through this a little bit because while sometimes it can feel like that, just because there are so many medication options there's actually a lot of thought and complexities that go into the decision making here. So first of all, whenever I think about a medication for one of my kiddos, what I always wonder is what the age of the child is, right? This is very important, along with what the underlying etiology of their LGS is, if it is known. Now, based on this, as well as the seizure type that the child has, for example, am I trying to use a medication to adjust for drop seizures? Whether the seizures are causing the body to drop because of myoclonic jerks, or atonic where the body loses tone completely, or even tonic seizures? Or am I trying to address absence seizures or atypical absence seizures? Or am I trying to address generalized tonic-clonic seizures? So the seizure type plays a big role here. And I also then like to look at what the other seizure medications are. As Tracy was just highlighting earlier, we should never look at, as just one symptom. We have to look at our child or as an adult or LGS loved one as a whole, because each new intervention, we need to know what the after effects of it is going to be. And we have to bear in mind that they are on multiple other medications, sometimes 5, 7 medications. I saw some hands elevated for early in some prior discussions about the number of medications some of our kiddos are on. I also like to know what other medications they're on outside of just seizures, also to see potentially whether if we need to worry about any drug-drug interactions. And sometimes we find medication combinations that I like to explain to many of my families as those that play really well in the sandbox together. So for example, some medications can actually boost the level of another medication up by 2 times, by 4 times. So we might not need as high a dose, right? So this is one of the reasons why in your clinic visit, your providers will probably ask you go through that medication list every single time, and they should go through the medication list every single time, right? Additionally, I always like to know about comorbidities, because if you're working so hard to get to counteract excessive sleepiness, and then now we're talking about a medication that's going to make you really sleepy, I don't want us to go fall back on any gains that we're trying to make here, right? One of the other important points is the formulation of the medication. I have had some of my little ones give me a lot of grief when I give them prescriptions for solutions, but I might need to switch it up to a sprinkle. One of my little guys is so smart smart that he can tell the difference between a 5 milligram dispersible tablet versus a 25 milligram dispersible tablet. So our kiddos are really smart, and so we need to take all of this into account as we try to figure out the right mix and match. Now, let me just go back to the previous slide. So while on some level, I can understand how it might feel like it just feels like we're just throwing a random option out there, but actually there is a lot of thought that goes into figuring out what the right options are for our child or our adult, our LGS loved one. And typically what I like to do is at the end of my clinic visit, I usually like to go and discuss 3 options with my families, and together we will discuss the pros and cons of each one of these options and make a decision together, and also at that time decide on how long we want to wait to see whether if this medication is going to be effective. And very importantly, I don't like to add one medication on top of another for our loved ones with LGS, we know that we often need to be on multiple seizure medications. But once we get to 2 or more medications, then I like to try to discuss which one of the other medications we're going to start peeling back on, so we don't end up with 5 seizure medications or 6 seizure medications. There has been a lot that has been published thus far about medications for our loved ones with LGS. This is a figure that was actually, I think Dr. Perry had presented this already, highlighting this. So I'm just going to go through just a brief point about this. So here, one of the guidelines, one of the crucial guidelines here is that if you look at the box that's colored in red up there, so the goals of anti-seizure medication therapy is 1, to optimize seizure control, 2, we need to minimize medications and side effect burden, 3, address cognitive and behavior concerns, 4, improve quality of life, and 5, lessen family burden. I know that you guys will do whatever we need to do for our LGS loved ones. At the same time, we need to make sure that if there's something which we can reduce any inefficiencies, for example, if I can avoid an extra trip to the lab for you, then that's what I should be prioritizing. So, so this comes up in conversations when we're discussing what the best medication options are, because some medications may require frequent blood work. And that's when I discuss this with my families, they tell me, at this moment, I'm having transportation issues. I don't think I can commit to this. And so then we have to think about what the right options are for you. All right, so with that in mind, let's talk about how we actually define status epilepticus. I feel that I'm probably preaching to the choir here. You guys have this lived experience with LGS. You are seeing seizures day in, day out. But while seizures are there, let's talk about how we actually define status epilepticus. So there are 2 time points that are important in defining status epilepticus. T1, or time 1, is when a seizure is likely to be prolonged, leading to continuous seizure activity, where if you don't use a medication to stop it at that time, it's most likely going to continue to progress and keep going and keep going and keep going. And time point 2, or T2, is when a seizure may actually cause long-term consequences, which can vary, but it may even involve changes in the neuronal networks. It can cause injury to the neurons. So there's a lot that there are things that we know about status epilepticus, and there's a lot more that we need to discover about status epilepticus. What we know about status epilepticus is when it comes to generalized tonic-clonic seizures, or GTCs, what we used to call grand mal seizures. T1, the time point at which you need to administer a rescue medication before it likely will evolve to continuous seizure activity that will keep going for a prolonged period of time, is 5 minutes. And T2 is 30 minutes. Whereas with focal seizures, where we see our loved one's consciousness being impaired, T1 is 10 minutes, and T2 is 60 minutes or greater. So you can see that the way we define status, it's not a one-size-fits-all approach. It depends on the type of seizure that our loved one has and how long it's been going on for. And when it's lasting for a prolonged period of time, it can cause changes to the neuronal circuitry, to the neurons, and cause injury there. What you will see is that, I'm sure if I ask you guys this, not everyone in this room will have just a generalized tonic-clonic seizure or just a focal seizure with impaired consciousness. In our LGS loved ones, what we're actually seeing is, we all know this, we're seeing tonic seizures, we're seeing absence seizures, we're seeing myoclonic seizures, and for those categories, we don't have a clear-cut criteria for where T1 is and where T2 is. But that is where there is a lot of research that's going into this, and is one of the areas which I'm interested in. I'll show you some preliminary data shortly. Very shortly. So this is some preliminary data that's come up from some work that we have done looking at our children with LGS. So this data set comes from the Pediatric Status Epilepticus Research Group. So it's a consortium it's an international consortium that accounted for around 20 to 22 large pediatric academic centers. And within this database, there were close to 1,000 patients that had status epilepticus. And what, together with a big team of us, myself, Dr. Tobias Lodenkemper at Boston Children's, and several of us looked at this data set. And what we wanted to do was, being that our children with LGS don't have clearly defined, we don't have a clear understanding of how status manifests in them, we looked at this cohort of 1,000 patients to understand how many of them had LGS, and how many of those patients, and what the status looked like in those patients. So what we found were, there were 51 patients in that cohort that have a diagnosis of LGS. And what we found was that only 24% had continuous seizure activity when they had status epilepticus. 76% had intermittent status. What that means is, when we look at a continuous seizure activity, basically means that seizure activity it started with stiffening and shaking usually, and it would continue and keep going for a prolonged period of time. But whereas our children with LGS, the vast majority of them had intermittent status, so they would have seizure clusters. By a show of hands, can I see how many of you, whether if this is consistent with your observations as well? Can you lift your hands if you typically see seizure clusters? Great. Okay. All right. Thank you. And what about, can I see a show of hands for just continuous seizure activity? Yeah, exactly. So it's exactly what the data shows, and this is what we are actually looking into with more detail. So what we then one of the issues here, as we were just discussing, is that our children with LGS present typically with seizure clusters. Seizure clusters, the definition is variable. There is no T1, there is no T2, as of now. However, we're working on this. And a part of this is because every single child and adult with LGS, every single one of our loved one, their baseline is variable. In the hospital, when you're admitted to the hospital, oftentimes in the hospital, one of the rough rules of thumbs that is used is, a seizure cluster is considered as having 3 seizures in a 24-hour period, or 3 seizures in a 12-hour period. But however, that is not sufficient for our loved ones with LGS, right? In such cases, what we then look at is defined clusters as 3 to 4 times increase in seizures over a 3-day period. But while this is a rough guideline, a lot of my families with LGS, they tell me that they can tell that we're going into a bad weekend. You know, your like spidey senses are tingling when you see that seizure coming on with a shortening interval between each seizure, right? So the goal here is each one of our LGS loved one needs a unique tailored treatment regimen to target their seizure clusters. So let's talk about how we actually treat status epilepticus. For our discussion, I'm going to focus on management of seizure clusters, because that's what our population, our children, our adult LGS loved ones have, right? So oftentimes you might see that your physician might say, let's do an extra dose of an anti-seizure medication. I often tend to use this, especially if, in discussion with the family, if we see that there's a gradual uptick in the seizures that day, once we know that once we hit that second seizure or the third seizure, we're going to go into continuous seizure activity, we try to give an extra dose of medication a little bit early into that cluster just to reduce the duration of this cluster. And sometimes we can actually do a load of medication where we do kind of a larger dose, but either orally or via G-tube if it's there. And at times we consider a short course of benzodiazepines, particularly during periods of illness or infection. But the most important thing here is that we need to identify and address the underlying etiology. Speaking of etiology, when we looked at our patients with status epilepticus, looking at those same 51 patients with LGS who were in status epilepticus, what we found was we looked at the reason why they went into status. And what we found was that the vast majority of patients went into status because of an underlying infection which acted as a trigger. The infection could be RSV, enterovirus, an unnamed virus but had viral symptoms, your viral panel came back unremarkable. And the second most common reason was potentially medication changes. What that means is a lot of times, perhaps like inadvertently, there was a generic medication was given instead of the trade name medication. So these were the common reasons for going into status in the LGS population. And lastly, I'll quickly cover when to go to the ER. So first of all, every seizure does not necessarily mean an ER visit. Reasons to go to the ER is if the seizures are not stopping with rescue medication, if you notice shorter seizures but our LGS loved one is not returning to baseline, of course if there are any airway concerns, okay. And then, lastly, I'll talk about how can we potentially prevent status epilepticus. So one of the best ways to do this is, you guys do this already, but regular clinic visits where ensuring that we're cross-checking the appropriate age and weight-based dosing of the rescue medications. These rescue medications can be given in multiple formulations, as you all know. So there's an intranasal version, there's a rectal gel, and there are oral disintegrating tablets. And extremely importantly is establishing a sick day plan. So for example, trying to come up with a sick day plan with your epileptologist to know at what point should you actually initiate a Klonopin or clonazepam bridge if your LGS loved one starts to demonstrate infective symptoms. For the seizure safety section, a few important things. I think you guys all know this, but if there are any newer families to our LGS community, seizures are scary. I think Amy had discussed earlier how 5 minutes feels like such a long time. It feels like time stands still. So try to first of all just let yourself acknowledge that and accept that it is scary. So stay calm and remember you do not need to subdue the movements. Keep them safe. Turn them to their side and time the seizure if possible. Obtain a video if you can and use the rescue medication if necessary. It takes a village to take care of our loved ones with LGS, so educate other caregivers, especially grandparents, any aunts, uncles, etc. We often tend to use helmets, particularly for drop seizures. There are several great seizure monitoring devices that are available, and the Danny Did Foundation has a great list of resources. We, of course, highlight the importance of caution in water, heights, and during sleep. Okay, so I'm hoping this Mentimeter will work this time around. Let's see if you guys can just scan this, and if our AV team can just, perfect, pull that up. Please name one seizure safety practice that you would like to adopt. And maybe, great. I'm seeing a pattern here. Perfect. All right. So I agree. I think establishing a sick plan, a sick day, sick plan can definitely help us understand how we can try to hopefully avoid ER visits and avoid ICU utilization. Wonderful. Thank you all for your time. I really appreciate it.